A patient who had upper GI bleed came in with coffee ground vomitus, melena, and the patient had OJD, and there's gastritis. Maybe some erosions, may or may not be any erosions. But whatever is the case, there's a definitive diagnosis. And you know that you have to start the patient on some acid suppression. So you would often start with PPIs, and after, say, 4 to 6 weeks, you would change it into a H2 blocker if these symptoms are suppressed, or if they had a repeat OGD and it showed good progress. Another important indication for PPI here is H. pylori and also Zollinger-Ellison syndrome. In H. pylori, you have something called triple regimen. In that case, it involves antibiotics and also a acid suppression. When it comes to acid suppression for H. pylori, you go for PPI and you don't go for H2 blocker. Because there are two reasons for it. One is because the PPI itself has inhibitory effect on the H. pylori bacteria, and second is that for the antibiotic to have maximum effect on the stomach and on the gastric mucosa where the H. pylori bacteria thrive, it is important to have a good acid suppression. That's why we go for a better drug. Last question is, what do we look out for? So when you start someone on PPIs, you have to look out for deficiencies because you are suppressing the acids to a good extent that you can have malabsorptions, difficulty absorbing, especially B12 deficiency, iron deficiency. And then you'll also have electrolyte disturbances, especially hypomagnesemia.
Kidney injury and increased risk of fractures. Again, these are not very common, but these definitely are very common. Among them, even hypomagnesemia is even more common. And one important thing to remember here is C. difficile infection. C. difficile stands for Clostridium difficile infection, and this is one of the most notorious infection caused by medication, and one among them is PPI. In H2 blocker, you have to keep an eye for anaphylaxis. So don't confuse this with anaphylaxis. That's a different subject.